Hello, let's discuss hyperaldosteronism. This is also called Conn syndrome, and generally, the most common cause of too much aldosterone is you've got a tumor in the adrenal gland secreting aldosterone due to hyperplasia of the cells there, and then that's going to cause atrophy of the zona glomerulosa due to a lack of renin leading to angiotensin 2. And angiotensin 2 is going to act on the zona glomerulosa to really upregulate aldosterone synthesis. So because you've got too much aldosterone, your blood pressure is going to be high. You're holding on to sodium that you pull in from the collecting duct. And because your blood pressure is high, do you think you'll be making any renin? No. So you won't be making any angiotensin 2, so you won't be stimulating the zona glomerulosa to grow. So you're going to have this big glomerulosa tumor that is secreting aldosterone, but the rest of the glomerulosa, especially if it's unilateral, the glomerulosa on the other side is going to be just minimal. It'll be flat. It'll be nothing at all. Take a quick look at what first aid has to say on the topic. You can have primary or secondary hyperaldosteronism. Primary means that it's a problem with the adrenal glands. Secondary means that you have some condition that is going to lower your blood pressure, that is going to cause you to make more renin at the level of the macula densa in the kidneys. And so that renin goes to AT2, which goes to aldosterone. That's secondary. That means the problem's not at the adrenal gland. And so something like a renal artery stenosis, textbook example of what is going to give you a lot of renin. Also, heart failure, just low blood volume in general, maybe something like cirrhosis where your oncotic pressure is low and your third spacing fluid edema into your peritoneal cavity. Also nephrotic syndrome, you're also going to waste protein that way. You have a significant proteinuria there, recall, and so that will also drop your oncotic pressure. Now, primary, most common cause of that is the adrenal adenoma, tends to be unilateral, or bilateral adrenal hyperplasia can be an inherited condition in which you're just throwing ACTH at these adrenal glands. And so aldosteronism is going to be secondary to the natural growth of these glands due to too much ACTH. And there are a lot of different causes of too much ACTH, but that's a whole different differential. In this SDL, we're mainly focused on the adrenal adenoma and on the clinical presentation and the diagnosis, the act of differentiating these different causes of primary hyperaldosteronism from one another. So what does pathoma have to say? Exact same thing. If it's primary, it's most likely an adrenal adenoma, though you might have a carcinoma more rarely. And then also this adrenal hyperplasia, which is often almost always going to be bilateral in nature. And so you have low blood renin in primary hyperaldosteronism. You have high blood renin in secondary hyperaldosteronism because the renin is what's giving you hyperaldosteronism in the secondary case. So in terms of this SDL, I think you'll get asked a question about secondary hyperaldosteronism. Let's say there are 5 coming from this text. Well, one of them will be patients got low blood volume or whatever, low oncotic pressure. Why do they have a lot of renin that's making a lot of aldosterone? You'll probably have a question about the clinical symptoms of hyperaldosteronism because due to the effect of aldosterone at the collecting duct, there's a few ion imbalances and you also get an alkalosis. And so they might want to probe you in that direction. You will probably get a question about how do you diagnose and tell apart different causes of primary hyperaldosteronism from one another. And then I would wager you would probably get one question about the familial hyperaldosteronism because there are 3 subtypes of that, and or the bilateral hyperplasia. I might get asked about either of those. And then you are definitely going to get a question about an adrenal adenoma because, again, that's the most common presentation of primary hyperaldosteronism. So we call the adrenals autonomous in this situation. If you've got a tumor on one side, then it is autonomously secreting aldosterone. That means you don't need any angiotensin 2 to get it to make aldosterone. It just is making aldosterone all the time. And then if you have this bilateral hyperplasia, then you're going to be extremely responsive to any angiotensin 2 in the blood, and you're going to make way more aldosterone than you ought be in response to that angiotensin 2. So I think I just said that the adenoma is the most common case, but SDL says that bilateral idiopathic hyperplasia is going to be the majority of causes of primary hyperaldosteronism. So how would this present? Well, you'd get a CT or something and the adrenals would be really big. Less common forms are going to include unilateral hyperplasia, which could be due to either micronodular or macronodular hyperplasia of the glomerulosa. And then there are two syndromes that cause that. And there's like acronyms for both of them. And that's in the Cushing syndrome SDL. I'm not going back to that today. Might see familial hyperaldosteronism with a positive family history due to a couple of different ion channel deficits or mutations. A carcinoma, again, more rare than an adenoma. Or finally, an ectopic aldosterone secreting tumor. You understand that ectopic is synonymous with paraneoplastic syndrome producing. So that means that you've got a tumor growing somewhere like the ovary or maybe the body of the kidney that is creating aldosterone on its own outside of the adrenal gland. Secondary is due to a drop of blood volume leading to stimulation of the RAAS axis, and you get aldosterone at the very end of that. The adenoma tends to be unilateral. It's called Kahn's adenoma. Cell of origin, adrenocortical cells of the zona glomerulosa, and they secrete steroids autonomously, which means independently from angiotensin 2 or adrenocorticotropic hormone. Most common mutation is going to be this potassium channel. Potassium channel J5 is the gene. Other less common mutations, I don't think you'll see anything at all about that. So they're small. You might miss them on imaging because they are in the middle of the adrenal gland. And if they're still, if they're still early on in their development, they might be secreting a lot of aldosterone, but not necessarily large tumors. And so, of course, you can miss them on a CT because CT slices tend to be something like, I don't know, every 1 centimeter or so, maybe a half centimeter. You cut them open and they're yellow because there's lots of fat inside your adrenals. Because steroids, your adrenal is the seat of steroid biosynthesis, and steroids are just 4-carbon lipids with some alcohols and ketones on them, and lipids tend to be yellow optically. So a tumor that's secreting aldosterone, you won't see any cortisol abnormalities, you won't see any blood ACTH abnormalities. Cortisol is the feedback inhibitor of adrenocorticotropic hormone. And if you had too much ACTH, well, you might get a hyperaldosteronism secondary to that high ACTH. And I guess that would be a primary hyperaldosteronism, because the adrenals would be pumping it out. But you're not going to see that with the adenoma. The zona glomerulosa is expected to atrophy. Understand that's because there's no angiotensin 2 to tell the glomerulosa, hey, you need to do something. And there's no angiotensin 2 because your blood pressure is high because you have a tumor that's making aldosterone. So with the lack of growth factor stimulation, the glomerulosa just goes away, kind of. So we call that paradoxical hyperplasia. And if I were going to ask you a question, I'd ask something about that just to see, did you skim the Spark Notes or did you read this SDL? Now we will talk about bilateral adrenocortical nodular hyperplasia. An overexpression in growth factor receptors on the surface of the adrenal glands may be responsible for the hyperresponsivity of the zona glomerulosa to stimulatory factors, leading to a big rise in aldosterone production. Focal hyperplasia, diffuse and focal hyperplasia. So what's that mean? Well, that means that throughout both adrenal glands, you see nodules of extreme cell growth. So loci almost, if you could imagine like points on a scatter plot or something. You will catch these on CT more often, I would assume, than you catch the cancers on CT. CT is always a good thing to get, though, anytime you're suspecting hyperaldosteronism. So what would I ask out of here? I would ask, you know, what do you see on histology? That's about it. Primary unilateral hyperplasia, you are not going to get asked about that. That is rare, like Mr. Clean with hair. Familial hyperaldosteronism. So you got some genes here, which makes me say, you know, if our teachers really want to be a fun teacher, then they'll ask you about the genes here. Type 1 is going to be CYP11 hydroxylase, which is also, if you got a deficiency in those enzymes, you get a 11 hydroxylase is going to give you ambiguous genitalia in females and also a hypertension. So you're going to have a chimeric gene here. Do you understand what that means? What does that mean? That means that you've got two different proteins just Elmer's glued onto one another. And so when you make one protein, you make the other one because there's no space in between these two proteins in the genetic code, you know, the CGA-TAGC. There's no space in between them. So when you make one, you make both. So because they're coupled, you just get too much of this enzyme. So that's going, what does CYP11 do? Well, great, it's right here in the SDL. CYP11 beta takes deoxycorticosterone down to corticosterone, which is just one step from aldosterone. So too much of this 11 hydroxylase enzyme gives the patient hyperaldosteronism. That's type 1 familial hyperaldosteronism. Now, type 2 is a chloride channel and type 3 is a potassium channel, and I'm not going to go any deeper than that. Type 2, chloride channel 2, type 3, potassium channel J5. So particular, telling them apart from one another. Well, patients got type 3 if they have hypokalemia, extreme hypokalemia. So type 3, it's the potassium channel one. And it's too leaky in this situation. It's not that it doesn't function. It's just that anybody who wants to go through it can go through it, you know? So sodium, calcium, other cations can pass through this dysfunctional potassium channel. So as a result, because this channel, whenever it's active, activity of this channel triggers aldosterone production. So if sodium and calcium can also activate the potassium channel besides just potassium, it's going to be overactive. So you will make too much aldosterone, hence the hypokalemia. And these patients are going to have a polyuria and a polydipsia because they're going to be losing a lot of water due to losing a lot of ions in the urine, I assume. And they don't really tell you nothing about type 2 in terms of making that diagnosis. So I would say you probably won't get tested on that. So now we talk a little bit about what aldosterone does at the collecting duct. This is all review. You lose sodium, then, well, you get aldosterone, you upregulate ENaC epithelial sodium channel, you pull sodium in from the tubular lumen, you pump out potassium. Sometimes you pump out a proton because you have to trade charges to keep everything electrically neutral. You are not walking around with a positive charge in your body. You're not walking around with a negative charge. Your body likes to be electrically neutral. So to maintain that, sodium in, potassium out. Therefore, the obvious ion panel findings that you need to really know, because you're going to see it in real life one day. Hypernatremia, hypokalemia, metabolic alkalosis due to loss of protons, because when you pull in a cation, you got to excrete a cation. So let's run through some of these other symptoms. If I were asking questions, I would ask you about the symptoms. That's relevant. You're a doctor. What does a doctor do? Diagnose. How do they diagnose? Symptoms. So patients are not going to have edema. And this is a phenomenon called aldosterone escape. Normally, you would expect if someone had just a gross degree of sodium in the blood, then water follows sodium. So your hydrostatic pressure goes up, up, up. And if your hydrostatic goes up, then that just presses water out of the bloodstream into interstitial space, creating pitting edema, or non-pitting rather. Or I'm sorry, it would be pitting because you wouldn't have any proteins in it. So it would be a transitate, right? Starling's forces. So you see pitting edema typically if somebody had a really high blood sodium, but not with aldosterone. And the reason why is because of increased secretion of atrial natriuretic peptide in response to the high blood volume. So ANP is created in the heart, hence the atrial, and it's going to go to your kidneys and tell them to push out sodium. And so that's going to compensate for the high blood sodium that's a result of hyperaldosteronism here. Patients have hypertension, definitely, because they're hanging on to too much sodium. And it does tend to be resistant to pharmacologic treatments, pharmacologic. So a refractory hypertension that you can't get rid of because they've got so much aldosterone that it doesn't matter if you throw an ACE inhibitor at them. These patients have a low renin anyways. And if you take a renin blood panel, you'll see that renin's at the floor, you know? So you're like, why do they have high sodium? And then you consider the adrenals and they're mineralocorticoid producing. So you say, maybe I get an aldosterone read on this person. Maybe I get a CT. Maybe I ultrasound it. Hypokalemia in a minority of patients because you've got to lose a lot of potassium to get hypokalemic. Your body does a very good job at maintaining homeostasis. Signs of hypokalemia on EKG, U waves, QT prolongation, ST depression. Polyuria is going to be a result of the hypokalemia-induced renal concentrating defect. Yeah, I'm trying to wrap my brain around that. I'm thinking it means that you got a lot of ions in your filtrate. So maybe if you don't have enough potassium, well, then you can't pull sodium in through ENaC because there's no potassium to trade with it. So you can't pull sodium back in. So sodium stays in the tubule past a certain point once you're hypokalemic. And so when sodium's staying in the tubule, then water's staying in the tubule, and then you're peeing a whole lot. Metabolic alkalosis, trading protons with sodium, ENaC, alpha intercalated cell, proton ATPase, makes sense. This could result in tetany. This could give you the symptom of tetany. And so what ion imbalance do we associate with tetany? Hypocalcemia, yes. So why does an alkalosis give you symptoms of hypocalcemia? I want to break this down right here, right now, because I'm going to talk about it in the parathyroid hormone video. But I know you guys don't watch all these videos. You know, you watch like 5 minutes of each one. You skip around, and that's so cool because I do the same thing too on YouTube. Let me get into these slides and tell you why a metabolic alkalosis is going to give you symptoms of hypocalcemia. So calcium travels in your bloodstream, and you've got two types of calcium in the blood. You've got bound calcium and free calcium. So what's bound calcium bound to? And the answer to that's albumin. So albumin is made by your liver, right? And it's got a lot of negative charges on it. And calcium is able to, because it's cationic, just kind of stick softly, gently, suavely on one of those negative charges and just float around in the bloodstream on the side of albumin. So you see on this graph here in the middle of the top that as pH increases, as the degree of alkalosis increases, protein-bound calcium goes up, and free calcium, which we also call ionized calcium, drops. So because albumin has a pretty negative overall charge. Well, why does it have a net negative charge? Because it's got a lot of aspartic acids and glutamic acids on it. And those are your acidic amino acids, which would contribute to a negative charge because they've got lower pKa's. And these amino acids just grab protons, because they're negatively charged at a certain pKa. What that means is that they can accept and buffer and sponge a proton that's floating around in the blood. So in alkalosis, do you have more or less protons in the blood? You've got less. So all of these negative amino acids on albumin, well, if they're anionic and unoccupied at a certain pH, then if there's no proton to bind to them, well, guess what? Calcium can step in and bind to that negative amino acid because calcium is cationic. And so what we see, this image here is the best one to look at, is that with a high blood pH, that means you have less total protons in the blood. So look at how calcium steps in to bind albumin under that situation. So you take a blood panel, patient doesn't have hypocalcemia. Why? Because a normal blood panel that's not taking fractionated or free calcium or ionized calcium, it's just going to tell you how much calcium is in there. And that includes calcium-bound albumin. But this patient might present with symptoms of hypocalcemia, hence tetany, because all the calcium in their blood is bound and it can't be used. Anytime something's bound to something else, you can't use it for anything. So what are you using calcium for that would contribute to tetany if you don't have calcium? And the answer to that is the maintenance of extracellular potential. So understand that calcium, being cationic, contributes to the voltage of extracellular fluid. And you recall from early on in your medical education and even your pre-medical years that cells like to be electrically negative on the inside, but you like to maintain electroneutrality in your extracellular fluid. So it's around 0 millivolts on the outside of the cell. It's around negative 70 millivolts on the inside of the cell. And so what we would say then, we would dub that a membrane potential of negative 70 millivolts, because that's this side of the membrane minus this side of the membrane, like where the negative 70 minus 0. There's your membrane potential. So recall that action potentials in the neuron only occur once you hit a certain degree of positivity with respect to your membrane potential. Your membrane potential, if we were to draw it out, has to go up to a certain threshold, and that threshold is about negative 55 or so millivolts. And once it hits that threshold, then bang, there's your action potential. Sodium, voltage-gated sodium channels open. What's the voltage that opens them? Negative 55 millivolt membrane potential. So the less calcium you have outside the cell, the higher your resting membrane potential is, because the extracellular and the intracellular compartment are closer to one another. And so in the setting of hypocalcemia, you're already partially depolarized compared to normal calcium. So it doesn't take a lot of voltage to activate and open up those voltage-gated sodium channels. And so muscles will be spastic, hyperreflexive, and that's tetany. So thank you for sticking with me for that. Finally, aldosterone damages the heart independently of its hypervolemic effects. And that's because there are mineralocorticoid receptors in the heart and on blood vessels. And that's why ACE inhibitors are so crucial post-MI, is because they prevent cardiac remodeling. If you've seen that in Sketchy Farm and you've been like, what is that? Well, then this is what that is. the binding of aldosterone to the mineralocorticoid receptor on the heart has really damaging, deleterious effects on your myocytes and their ability to heal through inflammation. Lab studies, primary hyperaldosteronism, no renin. Renin is so low. Secondary hyperaldosteronism, renin is up, yo, it's through the roof. Easy differential. So the diagnostic approach to primary hyperaldosteronism. You screen for it, you confirm it, and then you differentiate between subtypes. Screening is based on plasma renin activity and plasma aldosterone concentration. Renin is going to be low in these patients who have a high blood pressure if they've got primary hyperaldosteronism. But to confirm the diagnosis, you're going to try to suppress aldosterone. And if you've got some stupid tumor on your adrenal glands that is balling out of control, making aldosterone all day long, you're going to try to suppress aldosterone, but you can't suppress it because it's a tumor. It doesn't listen to feedback. So what's the suppression test? Fast them overnight. Give them normal saline. High blood volume should decrease renin, should decrease angiotensin II, should theoretically suppress aldosterone. But if it doesn't, you understand you've got primary or secondary hyperaldosteronism. And I would think that secondary hyperaldosterone, which is again low blood volume, that would get corrected if you put volume into a person. Even if they've got 60% renal artery stenosis, you're still going to put more fluid through that stenosed renal artery, and so that it should correct itself a little bit. So the saline test tells you you've got a primary case of hyperaldosteronism. Then finally, you're going to approach it from most severe to least severe. You really want to rule out the tumor first, which must be distinguished from nodular hyperplasia, because it can look similar. So you'll get a CT scan, and then you'll call your friend, the radiologist, to read it, because they're the adrenal glands, they're like that big. You're not going to be able to read that thing. So this is how it'll get phrased on a pathology test. This is exactly how they'll say it. They'll say that the carcinoma, they'll say they found something big on the CT scan, and that's a carcinoma. And then if they say, oh, they found nodules, plural, but they're small. Oh, well, that's for sure an adenoma. Well, a nodule singular would be an adenoma, and then bilateral nodules, if you saw abnormalities on both, then you would probably say bilateral adrenocortical nodular hyperplasia. So those are your three most common diagnoses and how to differentiate between them. You got to give them spironolactone. It's going to antagonize aldosterone. Got to. Then finally, secondary hyperaldosteronism. Patient has high renin. It's due to low blood volume. Give them saline, see if it corrects itself. If it does, it's secondary hyperaldosteronism. And that's all we got.